Welcome to the Indian Health Service Information Technology Modernization Project. My name is Jennifer Gillison with Kaufman Associates, and I will be your facilitator today. And I'd like to welcome Mitch Thornbrugh from IHS.
Thank you very much, and good afternoon, everyone, and maybe good morning for just a few of you on the West Coast in Alaska. Welcome to the Indian Health Service Health Information Technology Modernization Project listening session for January 14th. This is the second and final listening session related to the Dear Tribal Leader letter that was sent out soliciting feedback from our tribal, urban, and federal stakeholders in December. I do want to mention, though, while we're soliciting this is the second and final listening session, we continue to have open consultation in the Urban Confer regarding modernization itself. And so we do anticipate additional listening sessions on other topics as we move forward. But we are preparing to receive that feedback by January 24th regarding any feedback associated with the approach that IHS may take to the modernization project. But before we get underway, I want to turn it over to Mr. Gene Sorrell for an opening prayer. Mr. Sorrell.
Yes, quick school and suit and Lam's grandfather creator. We give you honor to allow us to take and participate this day. We give you thanks that you grant us this day to may we continue to strive to work and bless our families and our lives. We ask God, Creator, and a great spirits to be with us, to watch over us, take care of us, take care of our families and all of our loved ones. Take care of the world, Grandfather Creator, that you have so pleasantly given to us. We ask that we honor you and protect you and ask for your protection for us. For these prayers and all of our prayers, Grandfather Creator, I offer to you, Lem Special.
Thank you, Gene. So we do have a couple of technical notes for today. There are two icons located towards the bottom part of your Zoom screen. One is the chat bubble, which can be used to interface with folks on the platform, as well as for questions and comments. The second is the start video, so we can see everyone on camera. All phone lines have been muted. If you need technical assistance during the webinar, please type the issue into the chat box and one of our techs will respond to you. Please note that the webinar is being recorded, and I will turn it back over to Mitch.
Thank you. And again, my name is Mitchell Thornbrugh. I'm the Chief Information Officer for Indian Health Service, and I'm a citizen of the Muskogee Creek Nation. It's a pleasure to be here again with you today virtually. A lot of activity that is ongoing related to the COVID pandemic, so I appreciate everybody's attention and time on this important topic regarding the modernization of our health information technology infrastructure. I know how everybody is busy right now, providing care in their communities and supporting just all the various activities across the country. So again, do appreciate everybody's attention to this and your input during the meeting. This is really a great opportunity to hear the feedback and questions directly from our tribal and urban stakeholders. And so we really value this time, and we're going to spend about 20 minutes to 25 minutes giving you a quick update and some background, but we will leave the majority of the meeting to hear directly from you. Right now the IHS vision is on the screen. We like to start our sessions keeping that in mind, that we want to have healthy communities and quality healthcare systems through strong partnerships and culturally responsive practices as our vision. Next slide, please. And to reinforce the IHS strategic goals and objectives, and some focus on objective 3.3 with the modernized information technology information systems to support data-driven decisions. And obviously having a modern, mature health information technology infrastructure is extremely critical. And we're seeing that every day as we leverage our electronic health records, our health information exchanges, various data reporting systems to make sure that we can manage the pandemic and improve outcomes for our patients and our communities. So I think now more than ever, the need for modern health IT infrastructure is at the forefront of everybody's mind. And so I'm happy that we're talking about this at this time. Next slide, please. So just a couple of brief updates, and we're going to hear from Mitre a little later, but I want to make sure everybody understands that IHS is partnered with the Mitre FFRDC, and the FFRDC is the federally funded Research and Development Corporation. And this particular FFRDC is managed under the CMS, under the Innovation Center. So just wanted to make sure that we highlight that partnership. We're really excited with the level of expertise from across the industry, that being healthcare, government, and experience with the VA DoD implementations for their own modernization. Just really excited about the level of expertise that Mitre is able to bring to help us start up our program management office. Again, the program management office is that critical first step to managing a program and project of this size. Also wanted to provide a brief update on the interoperability pilot. So in the FY 2020 funding, there was a request to prove out our interoperability with the VA DoD as well as our tribal partners. And so we did launch the 4 Directions Hub to be that interoperability pilot as well as a potentially legacy data solution. And that's currently being piloted for eHealth Exchange with connectivity to the VA DoD and in really any of the Office of the National Coordinator or ONC certified commercial EHRs. That pilot is ongoing, but we've had lots of success there, and we're beginning some of the point-to-point testing directly with the VA. So we're excited where that's headed. Also wanted to announce that we've had a lot of discussions in close partnership with the firm, and the Federal EHR Management Group is the DoD and VA shared body, and that gives us a direct line of communication regarding their project status updates, lessons learned, and also the ability to coordinate any of those established methods that they've produced. I also want to highlight that the final report and technology roadmap were published in 2019, and the link to that is in the presentation for your reference, as well as articles and artifacts from the IHS Health IT Modernization Research Project that concluded last year. Next slide, please. Before I talk about funding, I also did want to announce that in December, we were able to recruit and select the Chief Medical Information Officer for Indian Health Service. And so I'm happy that to announce that we selected Dr. Howard Hayes for that position. And so we're excited to have that critical position filled as well. But with that, I want to talk about our current funding. Just to reiterate, in FY 2020, we were appropriated $8 million. The CARES Act of FY 2020 provided an additional $65 million to help accelerate the program. And then our FY 2021 funding levels have been finalized at $34.5 million. So we'll update this slide, but since the last time we talked, the FY 2021 appropriations have been finalized. And again, that was at $34.5 million. Next slide, please. And with that, I will turn it over to Sarah Gilmore to hear from the Mitre FFRDC.
You're going to turn it over to April Kaplan from the FFRDC.
Thank you. Go ahead,
Sarah and I work super closely together. Thank you everyone for being on this call. I'm April Kaplan. I'm a senior staffer with the Mitre Corporation that is partnering with IHS on this project, and it is an honor to be part of this effort. I just wanted to take a moment to just explain what the FFRDC is and why we are working with IHS. So Mitre is IHS's and HHS's federally funded research and development center. So we work on behalf and alongside the federal government. So we are not a traditional contractor in the way that most people think of contractors. We sit on the same side of the table as the government to work on their behalf to improve and provide programs and services that benefit, their populations that are served by HHS agencies. So we were created by government for government. We address problems on key challenges. In this particular case, it's the modernization, IT modernization efforts. And we have brought on multiple partners, which I'll explain in our next slide, who we've brought on to help this. But we provide innovative and cost-effective solutions for government problems. And like I said, in this particular case, we're talking about the IT modernization, setting up a PMO, developing a governance structure, and helping on the interoperability, all things that Mitre has worked across HHS and other federal agencies to help do. We don't develop any commercial projects. Anything we work on with the government is owned and is the government's property. We are a nonprofit. We function as a nonprofit and as an independent private nonprofit, which allows us to bring in other stakeholders. We work with a variety of government. We work with federal government primarily, but certainly, and tribes are responsible for implementing programs and policies, and certainly are the ones on the ground that see that programs and policies through and see the impacts of that. I'm talking quickly with my New York voice because we want to definitely hear from all of you, but by all means, would love to hear any questions you have about Mitre as we move forward, but I'm going to move to the next slide because I want to take a moment to talk about who's part of this effort. So while Mitre has great expertise on a lot of issues, we don't claim to be the experts on everything. No one entity is the expert on everything. And so we have the privilege and honor of working with a series of alliance members. And it's a pretty vast group of organizations that we work with. But in this particular case, for working with the IHS modernization, we've brought in Grant Thornton, Kaufman and Associates, and Safety Net Operational Solutions. And I don't necessarily need to read directly off the slide. I think it is important to emphasize the variety of expertise that the group has that we're bringing to the table, because in doing the IT modernization, it's very important that we understand, obviously the operational pieces, but we also understand the cultural and health impacts truly on the ground in tribal communities. So while Mitre has a lot of expertise, like I said, Grant Thornton brings operational and organizational transformation and certainly healthcare background. Kaufman and Associates brings organizational transformation as well, but a great understanding of Indian country and the reach of working in Indian country, which is really important. And Safety Net's operations solutions bring health data, information technology to the table and community and health IT experience as well. So while we have some cross-cutting expertise, we each also bring some very unique expertise to the table as well. And these partners, along with input from tribal communities and IHS and other federal agencies, and lessons learned from past experiences with other federal agencies, makes it a really good group of folks to work with. And now I'm going to turn it over to Sarah and let her finish out explaining Mitre and who we are and what we bring to the table, and then certainly we'll entertain questions. So Sarah, it's all you.
Thanks, April. Thanks, Mitch. Good afternoon and good morning to those of you where it is morning. My name is Sarah Gilmore, and I am very honored to serve as the project leader of the collection of teams from the Mitre perspective, as well as our alliance partners leading this effort. I wanted to share with you a little bit about the cross-section of expertise from a little different perspective than was shared on the previous slide that April mentioned. We recognize that this is a very important and we're honored to be part of this endeavor with IHS and the broader community to support the HIT Modernization Initiative. And we recognize that this is more than just an EHR implementation, and there is a broad set of expertise needed. We've composed a team with quite a wide variety of experience, and in healthcare, in IT, in acquisition, with relevant EHR implementation experience, but also with knowledge of data and interoperability and some of the other ancillary support services that really make the delivery of a unified healthcare system operate together. It's not just a single dimension, and for that purpose, we are bringing to bear quite a variety of expertise, so we can not only understand what you need to do for healthcare delivery and that enabling technology, but what it means in your environment, given how you have facilities across IHS, the tribal communities, and the urban Indian organizations. We also recognize the impacts that health policy have on enabling technologies and the targets of enabling or improving health outcomes. So that is another area of expertise that we believe is important for planning and adding to the foundation that has already been set. Excuse me, for the program. As was alluded to, we do have some experience from DoD and VA implementations as well, but also we have folks that have either worked with healthcare systems that are across the nation, Kaiser Permanente as an example, but also folks that have helped with implementing Cerner for the Alaska Native population, and folks that have worked in various healthcare systems across the country. So physicians, as well as systems engineers and technologists who have supported different health system and health IT implementations. I myself have a background in a wide range of systems engineering, acquisition planning, a large program, enterprise program planning, as well as applying technology in the healthcare domain, as well as other domains, financial services, other civilian agencies, such as Department of Homeland Security and logistics systems. So I look to bring all that to bear along with the team members to help you innovate and bring the right solution to meet the multifaceted needs for IHS. Next slide, please. And just to highlight some of the work that we're doing, and as part of partnering with all of you, we are organized and standing up the program management office, as Mitch mentioned, to take those next steps as outlined in the roadmap that was presented in 2019. Lots of great work has already been done to set the foundation, and we are excited to take the next steps with, first and foremost, standing up the program management office and the appropriate management operations to execute, monitor, and communicate the status of the program and how we're proceeding. The second task area is around governance and setting up the set of bodies that will work together to support decision making, collect advice, collect input, make sure that we have the right forums for looking across the whole landscape of needs and having those represented as we go forward. The third task area is around acquisition and program planning to make sure the right products and services are acquired in alignment with the decisions made and the plans that are outlined based on the approach that is everyone is in agreement with moving forward. The fourth area is around more of the engineering and architecture, the analysis and planning to get all those pieces and the necessary specifications, how they interoperate together to make an effective integrated solution of the enabling technology to modernize and improve the health outcomes. And then the fifth area is around organizational change management, which includes stakeholder engagement and communications to make sure we are effectively understanding and the needs and the impacts that the changes are going to have on the whole community at the various stages in the life cycle, from new ways of thinking about how we work together for a to again look at ways to unite and find some commonality that can be leveraged. That this community has done that in many different ways and has exhibited that, and we want to continue to build on that. Also as new capabilities are introduced, making sure that people have the right training and understand what is how to use new technology and what the impact is. New things and change, we experience it every day, but also sometimes it's human nature not always to be ready for that change. So our goal with that task area is to help with that readiness and prepare folks for any changes and impacts that the new capabilities will provide. And that's a quick summary. Again, thank you all. So honored to be part of this, and I will turn it over to Mitch.
Thank you, Sarah, and thank you, April, for that overview. I want to start off by talking a little bit about the high-level timeline, just to set expectations. This is the same timeline that we established during the Modernization Research Project. And it really just to set that expectation that even with an aggressive schedule and timeline for some of our deliverables, it's still going to be towards the end of FY 2022 and possibly into FY 2023 before we would see a site or any initial capacity converted to a modernized health IT infrastructure or a replacement for the RPMS infrastructure. So just wanted to set that high level timeline. That's one of the most common questions. And we're right now in the middle of establishing that PMO, getting the acquisition plan together, as well as moving the project forward in the 5 task areas that we just heard about from the Mitre team. So next slide, please. So the Modernization Research Project identified 4 high-level approaches to how IHS and tribes and urbans can approach the modernization. And the first one, stabilize RPMS, is really almost a prerequisite at some level, recognizing this will be a multi-year project, and not everybody will convert at once, that we still have a long road to support the existing RPMS infrastructure. And we want to make sure that the thousands of users and millions of patients that rely on RPMS for high quality care have the level of support they need. So we will be looking at making those logical enhancements, doing the things that prepare RPMS and our sites for a transition to a modernized infrastructure. And that activity generally falls under that stabilized RPMS approach. So just wanted to highlight that portions of one have to be addressed because of the multi-year approach to the project. The second approach is to rewrite RPMS, and so that's to take the code and rewrite those legacy software and create the new functionality and modernized infrastructure that we need based on a rewrite of RPMS. The third approach is a selective replacement, where you take portions of approach number 2. You obviously wouldn't leave the old legacy code in place, but you do modernize portions of RPMS and augment that with commercial solutions. And the fourth approach is a full replacement of the core infrastructure or the core replacement of the RPMS code base with a commercial software to do those functions. So those are the 4 high-level approaches that IHS will have to make a decision on how we will approach modernization. And this is where we're looking for feedback from our tribal, urban, and federal partners around thoughts and questions around those approaches. And so with that, I think we'll open it up for questions at this point.
Thank you. You can enter your questions or comments into the chat, or you can unmute your phone line by clicking the microphone at the bottom left corner of the Zoom interface, and you can go ahead and ask questions.
Mitch, this is Stuart Ferguson. Can you hear me okay?
Hey, Stuart. Yes, I hear you.
Hi, Mitch. So I want to commend you guys. This is of course a giant project and been years in the making and will be years in the building. I think the question that I have is, so you mentioned that it would be the end of FY22 or into FY23 before you start to see a build out. So, as tribal organizations, what can we expect to see happening this year? And probably more importantly, how are you going to engage tribal partners to make sure that we're feeling included and able to share not only our experience, but our needs going forward?
Hey, Stuart, great question. And thank you. It's good to hear from you. Of course, Stuart, you've got lots of experience in Alaska and have done much of this work yourself. So, that's one of the key strengths that I think IHS has is with our tribal partners who have led in this area. And again, we want to make sure we leverage the leadership that tribes have already shown and really learn from the paths that have been blazed by your leadership and other leaders across the country as they've moved forward with modernizing infrastructure in their tribal communities. And so, we're not expecting to have conversions until late FY 2022 or early FY 23. We do anticipate the build will start in earnest at the end of this year and be completed through the end of FY 2021 through FY 2022, depending on the approach and the acquisition package and solutions. Will obviously dictate some of that build environment. But what we learned from the industry, from our tribal partners, and those with experience doing this is that can be anywhere from a 12 to 18 month build process. And so we want to make sure that we have adequate time to do that. And so really the timeline's just to help set that high level expectation of why that takes so long. So not everybody that has done this work may realize how much work is involved with building that infrastructure. But we wanted to recognize that. And so the timeline just recognizes that. And again, the FY 2022 is when we're at the end of FY 2022 is when we're hoping to start initial capacity or pilot sites, with the modernization. I shouldn't say pilot sites, but those initial sites to convert from RPMS to whatever the modernized solution is. And as you can see from the approaches, there's not an approach that doesn't include some sort of conversion. So we know that conversion and go live is going to be a part of that plan, regardless of the approach. As far as in making sure that we have tribal stakeholders included, We're going to continue, as I stated at the beginning, to have additional listening sessions on various topics. So we continue to have open tribal consultation and urban confer on the modernization topic as a whole and in general. And so we do anticipate additional outreach there. But we'll also continue to reach out to our stakeholder groups that were established under the Modernization Research Project. And so we have the Information System Advisory Council, which you and some other technology professionals set on to help make recommendations to the director about technology. And so we'll continue to leverage that body, as well as the Direct Service Tribes Advisory Council, the Tribal Self-Governance Advisory Council, and the urban groups. In addition to that, we have lots of stakeholder groups across the country on the federal side with the NCCMO, NCC councils. And so we'll continue to interact with them, as well as making sure that we're meeting with our area directors to make sure that we're fielding any questions that may be coming up through them and providing them good information to share in local and regional meetings as well. So it'll take a lot of effort to keep that engagement high, but that is our desire. And we think we've set the PMO and the associated tasks and the work plan to address that. But we do know that it's a pretty rigorous path. We know from the Modernization Research Project that many of the stakeholders will be meeting with quarterly. And while that doesn't sound like very often, when you multiply that out, we end up having half a dozen meetings a month where we're providing updates and to various groups as this moves forward. So did that answer your question, Stuart? I couldn't write as fast as you were asking that question.
Well, I appreciate it, Mitch, and thank you. Yeah, and I would just like to say that, I know that folks in Alaska and in many other places have experienced with moving to a COT CHR would really like to participate, because yeah, we do feel like we have a lot of experience. So I appreciate you including us. Thanks.
Thank you, sir.
We do have 4 questions in the chat box. The first one is, how will the selection process work for sites that want to be involved with modernization process?
So once we make a decision on an approach, we will develop an acquisition plan to meet that goal. And so when we talk about a selection, typically what we're talking about is from a federal standpoint, the federal system will have to make a procurement. And that could be one or a host of solutions depending on the approach. And so it's really that acquisition plan that will determine what that selection will look like. And that will be a very inclusive process. The last thing we want to do is to have a small group of people select, an EHR. But through that acquisition plan, we will have an appropriate level of engagement with our federal and tribal stakeholders to make sure that their voice is heard about priorities, functionality, what's most important in the way that we approach it. But regardless of the system that we select, this is really an opportunity to address the way we support health IT across the country. So there's opportunities for us to improve the stability of whatever solution we have through how we design those support models, making sure that we have adequate levels of training, and honestly making sure that we have adequate levels of financial support that it takes to run a modernized health IT infrastructure. And we know that that's different than what we have currently deployed for the resource patient management system. And so we do hope that this becomes an opportunity to address longstanding needs for additional staffing, support, and systems in a way that improves the stability and coordination of care across the country. Thank you for that question.
Thank you. We have another one is, how can this process also work at modernizing tribal HIT platforms and infrastructures, or is this part of the current package?
Thank you for that question. So as we stated earlier, and we heard from Dr. Ferguson, who's already modernized in Alaska, we understand that the landscape is a moving target for modernization, and it has all the complexities associated with tribal self-governance and 93-638 regarding choices that tribes may take to modernize their own systems, and whether that's to reuse RPMS or to go off and use commercial off-the-shelf software using their own funding sources. And so we're really taking a holistic look at what that means for IHS. And so we're looking to build the modernized infrastructure around data, care coordination, and health information exchange rather than a single EHR. So we do contemplate that our tribal partners have already invested in commercial solutions, and we want to enhance that investment and not detract from that investment. With that being said, there are also partners who rely on us to make sure that we provide an appropriate, high-performing health information infrastructure. And so we really have to balance the way we approach that. And so again, I would say that we're focused on a data-centric model where the electronic health record sits on the periphery of that model and is at a peer level with our partners. And so Indian Health Service, we envision, needs to select and operate an enterprise EHR in a way that's efficient and effective and can stabilize our current models. That being said, we understand that tribes can make their own choices or have already made their own choices about electronic health records. And so we wanted to make sure that their choices can sit at a peer level in the infrastructure, so that if we select an Epic or an NextGen or whatever the solution is, that doesn't devalue what our partners have selected, but it also creates opportunities for tribes who partner with us directly and leave their shares to either use the solution that we set forth or are able to move forward and select their own solution depending on the recurring funding levels and monies that might be made available through the federal budgeting process as recurring dollars out to tribes. So very good question. I hope I touched on the high points for that.
Thank you. So the next one is the pandemic has heightened our need to have a better functioning EHR. Tribes that are still on EHR aren't receiving the IHS support needed to continue to provide good care. Will there be additional support for those tribal programs in phase 1?
Yeah, absolutely. So when we talked about stabilizing RPMS, that your question really gets to the heart of the challenge, and that's recognizing that the pandemic is pushing the limits of our current infrastructure, and it's exacerbating known issues, it's highlighting new issues, and we have a great team that's working very hard to stabilize that RPMS system, and we've seen patches come out recently, well over 100 patches in the last year. And enhancements to those solutions. But most importantly, we were able to deploy the 2015 certified health IT package for RPMS, and that was an important milestone. Again, signaling our pursuit of quality reporting and to support industry standards around how an EHR should function. But additionally, we had packages and releases associated with being able to report vaccine administration. That work is ongoing. To be able to report testing as required from HHS, CMS, and others. And so we know that why that's important for us to keep stabilizing RPMS front of mind. And specifically, we know that the level of support that an individual site has varies widely across the country. The way the RPMS system is distributed and managed and supported across the country creates lots of opportunities for individual vacancies to really destabilize the way RPMS runs at specific locations. And so we're trying to overcome that with additional training, with additional enhancements that will reduce the overall support burden, automate as much of that support as possible as far as configuration and interfaces. But overall, we will have to come up with a robust RPMS stabilization plan to make sure that we're addressing that over the next, 7 or 8 years while we have thousands of users and millions of patients relying on RPMS.
Thank you. So we have a comment as well as question, and it's a two-part. So I'm just going to read all of it to you. I would like to hear how tribes are going to be involved in the project management, particularly those sites still on RPMS. This is unique to VA, DoD, and other conversions in that tribes operate over 50% of the agency. We are not stakeholders, we are governments and partners on this. And just to elaborate, it is not simply a communication / answer questions effort. Tribes need to have a participatory role in decision-making as a project implementation moves forward.
Yeah, thank you for that question. I see that that came from Miss Melanie Forkiller, so I appreciate that the way that question was asked. And you're absolutely right. With tribes operating significant portions of the infrastructure, we do need to find a way to address that. From a project management standpoint, we are creating the charters now, and we're looking at opportunities for not only tribal stakeholder engagement, but how do we bring those thought leaders, those experienced professionals across the country, whether they're in a tribe, an urban, or a federal setting, to make sure that we have the strongest team possible to help make these decisions. So this does come down to some federal procurement activities. And so we're exploring, and looking to push the boundaries on how we can bring in partners into those conversations. We are also leveraging the existing knowledge base and information that's out there. And hopefully we can engage through listening sessions and tribal consultation, be able to receive those ideas and get, understand the landscape and challenges of the many different partners and how our decisions will affect them. So I don't think we have a perfect answer to that yet, Ms. Forkiller. But again, this is an opportunity to hear directly from you. Well, how do we get to that level of decision making that you would like to see tribes involved in? Thank you.
Thank you. There's a follow-up from a different person is how will tribes be represented on the governance structure? Specifically, will there be tribal rep seats on the governance committee?
Thank you. I see that question's from Melissa Gower. Good to hear from you as well. And great question. So the governance structure can be somewhat challenging. We're exploring all the options to look at either a FACA exemption or potentially a FACA committee to make sure that we can have appropriate representation on that governance structure. So we are opening that up we have heard consistently from tribes through the Modernization Research Project, a little bit as a follow-on from Ms. Forkiller. And this is a great question, Melissa, that we know that we want to see tribal seats on that committee. I would also say that I think that's somewhat inferred by Dr. Ferguson's questions earlier as well, touched a little bit on how exactly we'll get that partnership situated.
So we have a few more questions. Will virtual telehealth medicine be part of this modernization, or is that a separate initiative?
So it's a little bit of both. We think that there's a huge need for virtual telehealth visits, whether that's more than telephone, maybe not always synchronous video, but some level of virtual healthcare delivery. The pandemic has really highlighted that that's an opportunity to increase access in our communities. While it does exacerbate the digital divide and put pressure on our rural connectivity, it also is a way to deliver virtual resources into very remote areas of the country and communities that might not have access to that level of care otherwise. So we think that that's going to become a very powerful trend going forward. And there's current efforts to expand that now. But we also recognize that we want to make that a critical capability as we look at modernization. And so it's a little bit of both. There will be ongoing efforts now to expand virtual care, but we will be looking towards the future and making sure that any modern infrastructure is well prepared and well situated to support virtual care.
So we have another one. As you know, many tribes have already chosen or are in the process of choosing a new HIT system. IHS has withheld much of the HIT funds from being shared with tribes. When and how will all HIT funds be dispersed to tribes through tribal shares to assist us in our HIT infrastructure endeavors?
Yeah, great question. We talked a little bit earlier about the complexities of 638 and the need to establish, a replacement for RPMS. And so as we continue to look for recurring funding sources, we are looking to identify the level of need across the country so that information can be shared in the budget process to make sure that long-term, not only do we have the money to convert the RPMS infrastructure, but that we have appropriate levels of funding coming back through the agency and to tribes to maintain and support what we feel like would be appropriate for a modernized health IT infrastructure. And as we've said at the beginning of the meeting, the long-term sustainability of a modernized health IT infrastructure is going to require resources. It's going to require resources to stabilize RPMS. It's going to require resources to replace, RPMS. And it's also going to require resources to make sure that our tribal partners have access to those funds to make sure that they can maintain their own infrastructure. So we don't have those answers yet, but that is definitely front of mind for the project team. And we continue to try to support those conversations with our findings. And we know that the acquisition plan that IHS is going to undertake over the next several months is going to go a long way to really identifying what level of support is needed across the country for modernized health IT infrastructure. And we hope that again, plays back through the federal budgeting process with support from tribes and others to make sure that we get the level of funding that we needed that can be redistributed to tribes through shares and through existing methods to make sure they can support their own infrastructure. Thank you.
Thank you. We have a few more. How will the modernization process help support those urban clinics already on a COT, specifically in terms of data collection for reporting? Currently, there's a need to have clear communication on those needs as they change.
Yeah, absolutely. And so we've seen lots of impact in this regards to the NIPERS investment. We're working with additional COTS across the country or commercial off-the-shelf software to make sure that we can onboard them and provide the level of data, either gathering or reporting or both in many cases in various venues. And then there's new needs arising that we're looking for how we can approach those challenges. We talked a little bit earlier about the COVID-19 pandemic and the need to do vaccine reporting as well as some other testing and reporting. And we know that those have impacts not just on the RPMS solution, but on the way that we transfer data, whether it's just an agreement or if we're having to set up an aggregator as we have for some of our solutions. So we are looking to the modernization project to start to fill those gaps where we see them forming. Thank you.
Sure, we have a few more in here, Mitch. Once the acquisition plan is established, what plans does IHS have to conduct a pre-solicitation conference or conferences to ensure the interested parties clearly understand the IHS need in allowing quality teaming arrangements to be established in pursuit of the requirement?
Yeah, so and I would welcome any input from Mitre here if you want to get into any more details that you want to share about how the acquisition plan works. But I would just say that yes, the acquisition plan has to address those. And so as we move forward and finalize that acquisition plan, which is after we make the decision on our approach, that we will make sure to address that clear communication with the industry.
Agree, nothing further. We would expect opportunities for that as part of the acquisition plan, but the details of that are yet to be determined.
Okay, thank you, Sarah. The next question we have is, will the health IT system allow for electronically connect patient records for community-based service providers such as tribal organizations? And 2, how will IHS incorporate security and safety measures in the process of working on the project?
Yeah, great question. Yes, we are focusing on how we will connect to community-based services, community partners, and specifically we're asked in the FY 2020 funding language to make sure that we can connect to the VA, DoD, and tribes. But we also know that that extends to our community partners, whether that's partners that we use for purchase and referred care, or if that is just partners that are in our communities and we know provide care to our patients as our patients come back and forth, between those health systems. And so community exchange through health information exchange technologies is critical. It's part of our stabilization plan to improve RPMS's ability to exchange information, as well as wanting to maintain that ability in a modernized infrastructure. And so I would point to the 4 Directions Hub pilot that we're currently undertaking and testing with the VA and DoD for connectivity. But that solution will also provide mechanisms for RPMS to be able to communicate with community health exchanges, regional health exchanges, and some state-based exchanges. And so the partnership with eHealth Exchange is a critical one that establishes a lot of connectivity. We're also going to look very closely and really leaning into connecting to Commonwealth, as well as some of the other national health information exchanges, so that we can meet our tribes and partners where they're at. But we do anticipate, having dozens to hundreds of connections to health information exchanges across the country. And while that's in RPMS, it's very distributed, and the 4 Directions Hub is going to help us with that. But then in a modernized environment, we do anticipate being able to do more national high-level connections to get a lot of data moving quickly. And great second question, or the other side of that coin, is how will we incorporate security and safety measures in the process of working on those projects? And we're using modern standards even for the RPMS system. So we're making sure that those exchanges are secure, auditable, that we have the security lined out in the DURSA-like agreements, or the data use and reuse agreements. And so that people are establishing their reason for requesting the information, that it's coming from an appropriate requester, and that we have those security agreements in place, as well as the technical connections that facilitate those users logging in and asking for that information. So that was pretty high level, but it'll be a little harder to go deeper than that at this time.
Thank you. Another message we have is, aside from stabilization, are the other 3 approaches equally under consideration, or is there a predisposition towards one of them based on analysis to date?
Yeah, really good question. So stabilization is really kind of a prerequisite. We still need to take one of the other approaches. The closest that we came to a recommendation was the analysis from the Modernization Research Project. And it came short of telling us which approach to review, other than to say that they were all 3 were valid approaches. So I would say that the options 2, 3, and 4 are on the table, and option 1 is somewhat of a prerequisite.
So we have a number of questions again about projected budget, implementation. So maybe another review of the high-level timeline and funding, Mitch?
Sure. Was there a specific question in there? I may not be in sync with the chat questions.
It's okay. Well, they're asking about projected budget over how many years, implementation, etc.
Yeah, and so at a high level, the modernization research project, looked to establish, what it would take, and we know looking at VA parity and the modernization projects that can be anywhere from $3 to $8 billion over 10 years. But we really, until we get to an approach and we start to nail down an acquisition plan and we start to think about the in-depth planning around the capital to improve infrastructure site by site, then we're going to have a hard time, nailing down a more exact estimate. But we know that it's a significant amount of funding. We know that we need annual recurring funding for operations, and we know that we need capital to do the work to convert. And the work to convert, is training, offsetting labor that may be lost at a site during conversion and training, making sure that the site's infrastructure is at a level that their biomedical equipment, their imaging systems, and all those ancillary systems that you don't always think about, lab, et cetera, are able to connect to a modernized health IT infrastructure. And then there's site remediation, where the cabling, wireless, computers even may not be what they need to be to handle the modernized infrastructure. And so all of those things have to be brought to bear, and we're going to use some methods to project some of that and to tighten that up through some of our research work or through some of our planning work. But ultimately, that will come down to site-by-site implementation plans that will be further into the project. And so, that at a high level just is some of the challenges with getting, too in the weeds, in any budget projections. But we are thinking about what those buckets look like and make sure that we are not only thinking about what that means for our infrastructure, our current level of investment, as opposed to what we think is a reasonable level of investment to maintain a modernized infrastructure. But we're also pulling some lessons learned from the VA and DoD about some of their planning around those costs. And we know that there were some lessons learned around site remediation. And so that's why that's top of mind for us as we do our planning as well.
And the projected year for the new solution to be available to implement by a tribe?
Yeah, so we don't anticipate having any conversions until the end of FY 2022 or early FY 2023. And again, that gives us time in FY 2021 to complete an acquisition plan, select it, and then we need 12 to 18 months to build that solution before anybody's converted to it. And I just wanted to circle back on the budget question, and we continue to advocate with our tribes to share their information regarding what they think those costs would look like. And then we continue to point tribes and stakeholders and partners back to the mechanisms that they have in place now for the federal budgeting process.
And then we have a couple more. For the services work, will this follow the Indian direction, and will the procurement of the product be separate from the procurement of the services?
So there's absolutely an opportunity to make sure that we support an appropriate acquisition plan. I don't know that I can commit to any of those details other than to say yes. We are looking at how such a large acquisition is appropriate, not only to stage it correctly, but to bring the right partners in and to create opportunities across the country.
Thank you. We have a few more. Will there be a capacity to collect tribe-specific data and share relevant data sets with the applicable tribes so that tribes can learn more about how their tribal membership is impacted by specific public health issues?
Without getting into too many specifics, as we look at how we collect data, our data use agreements with tribes, we want to be respectful of how we reuse data. But I would say that yes, part of a modernized infrastructure is the ability to provide appropriate public health reporting, community-based reporting. I just want to make sure that when I say that, I intend to be respectful of tribal data sovereignty, we're not saying we're going to share everybody's data with everyone, which is the flip side of that concern that comes up with this question. But we certainly want to have an appropriate infrastructure to be able to quickly and professionally aggregate data and provide public health reporting to our partners.
Thank you. So we have another question. One of the key findings in the strategic options report was determine the appropriate topology and architecture for the system supporting analytics, whether it be locally or centrally deployed. How is that being addressed in FY21 through FY22? An analytics solution needs to be built concurrent with or ahead of the EHR deployment.
Yeah, so we're having those discussions now, and part of it is the NIPERS investment is very structured in the way that it meets some of the requirements of that program that were funded a certain way. But we're really looking at what that means for modernization. And so we're seeing the convergence of the NIPERS discussions, the public health reporting discussions, and then what would an analytics solution look like that's agnostic to an EHR. But I would say, that's part of that modernization work that the PMO is starting to engage in now so that we can document those discussions. But I agree with Stuart with the inference in the question that in FY 2021 and 22, as we architect the solution, not only do we have to be data centric in the way we handle health information exchange and the modern the connectors between the modern electronic health records that will be in the ecosystem, we also have to mature our analytics platform to be EHR agnostic.
Thank you. Another question is, when conversion happens, will legacy information be available in the new system?
Yeah, that's a great question. So this is one of the challenges that we're already hearing loud and clear from our partners who have modernized, from the industry. Also my experience in this arena is that many times the only solution is to freeze the RPMS data. And that falls short, I think, of what we all would expect out of a modernized system. But there's really limited solutions now. And so we feel very strongly that we have to create a solution that we host, but also a solution that tribes and our partners can recreate to make sure that we can extract the valuable data out of RPMS, put it in a low code or no code environment where that information can be sustained for future generations and either quickly imported into a modernized solution or referenced, in the future back to, a database type system. But again, the idea would be is to mature that from where it is now, which is, freezing RPMS has some challenges because you really start to get locked into package levels. Those get locked into support models for the database, and in this case, InterSystems. So you start to run it, into conflicts with being able to upgrade RPMS. Then you run into problems upgrading InterSystems, and then you're going to run into problems upgrading the Windows operating system or the AIX system that it's sitting on, ultimately leading to needing to turn that system off because you can't secure it and you can't leave it on the network running even in read-only mode. And so we know that there needs to be a long-term solution for the legacy data repository, and we do plan to address that in the modernization project.
Thank you. Another question is, I appreciate the recognition to include costs for the entire ITU system as part of our budget request. We are entering national budget formulation next month with IHS. Will we at least have a preliminary estimate to advance to HHS and to the president for 2023?
Yeah, I think the only number that we've had is that $3 to $8 billion over 10 years. Melanie, we're, until the conclusion of the acquisition plan, we'd have a hard time supporting any other number. And I would say that that number is really just a representation of VA parity. And I hope that's helpful.
So another question I received is data used versus using a single EHR. How often will that data be reviewed and used to implement this balance? How will we know we are successful in that process?
Yeah, is that question in chat? I may need you to restate that.
No, it came to me directly. It's data used versus using a single EHR. How often will that data be reviewed and used to implement this balance? How will we know we are successful in that process?
Okay, I'm struggling with understanding the question there. You know, I would say that my assumption is that the question is around how do we know if our data is being reused? And so, you know, we'll have transaction records and know how many times that either an HIE connection or our central data repository is used for reporting. You know, the HIE is more the real-time patient care coordination centered model, with the data reporting being more of either a NIPERS function or as Dr. Ferguson mentioned in his question earlier, a function of reporting from an analytics platform. And sorry, if that didn't touch on the question, it might need someone to restate that. Thank you.
Thank you. I'll let you know if they restate it. Those are the questions that we've gotten so far. Again, you can enter your questions into the chat or you can unmute and ask questions. We do have another one that came in. Will some of the work that was described on the PMO slide go out for procurement? Example, the ORG change?
Yeah, great question. And so the partnership with the Mitre FFRDC, you know, really allows IHS and Mitre to bring a lot of resources in the industry to bear quickly to create a lot of capacity early on. We've been very clear with Mitre, and Mitre's been very clear. They're helping with some of this initial stand-up of resources, but we recognize that we want to long-term, you know, go out and solicit partnerships and subcontracts to shore up the program management office. So each task is coming up with some of those deliverables now. So part of the work of the PMO is to structure those acquisition packages, not just the acquisition for what we would call the replacement of RPMS or the modernized infrastructure, but also a lot of work to make sure that we have partnerships and capabilities that we procure to make sure we can meet those various tasks. And so specifically task 5 around organizational change, we know that that's extremely critical. You know, the replacement of an EHR and the upgrade of the health IT infrastructure goes well beyond information technology at all of our organizations. I think we would all agree that this infrastructure is really the operating system for our healthcare delivery systems. And, you know, we want to make sure that we've got adequate support and partnerships to address those organizational change challenges, recognizing that this project is going to impact everybody in healthcare and in the healthcare delivery model. So thank you for that question.
So any additional questions you can put into the chat box, or you can unmute your line and ask questions. We do have time available.
Quick question. I typed a few of them. This is Tom Bonnie. I'm with Cognac. And I'm a little curious on the stabilization of the RPMS, you know, and the other activities of the renew and, you know, the other options. How long how long do you think you'll go out and, or when will the stabilization opportunity be coming out? And is that like a year-long effort to do stabilization while while you're getting ready to do the other procurements?
Yeah, so I don't think we view that stabilization as a single procurement, but as a body of planning and work to make sure that we're addressing ongoing needs of RPMS. So I don't think that there's a clear start or finish because we're continuing to do that. But it does formalize our commitment to make sure that we're sending clear messages that we are going to continue to support the RPMS users and the patients that rely on it. And so it's a body of activity over the life of the project to make sure that we're keeping up with those standards. And so I mentioned earlier the 2015 certified edition. That's I think we were in arrears of reaching that, but it really represented a milestone in our commitment to support quality reporting because there was not a financial return on investment for that work. But it ensures that we and our partners can continue to report to CMS quality outcomes in their communities as they need for various programs, and again, to support quality outcomes across the country. But recognizing that we've completed that milestone, we're preparing for the next iteration and advancement of that bar moving on us, and that's through the 21st Century Cures Act. And so there's going to be something that comes after that. And we're just going to have to continue to make sure that we keep RPMS at an appropriate level of investment to make sure that we don't, that we don't fall short of that quality bar and our commitment to having a functioning and high quality electronic health record as we modernize.
Great. Just a comment on the converting legacy information over. I was part of the DoD effort. I wrote the data migration strategy, and we ended up only looking at elements that were, around critical healthcare needs, only, for patient safety items that are, like drug interactions, are they allergic or something like that. So therefore, you don't want to be bringing over everything because that is a nightmare.
Yeah, absolutely. And, we're having those conversations, just from a project standpoint about how do we stage the questions about, what's the value of the previous data and recognizing some of the complexity that you just mentioned. Overall, I would say where we're at is just we're recognizing that there's data that needs to come over, but we're also recognizing that any data that's brought over needs to be managed, go through quality control, and there's resources needed to move that data.
Well, thank you for all you're doing on this.
Thank you.
Yeah, just a reminder, you can type your questions into the chat box, or you can unmute your line to verbally ask your questions. We still have time available.
And I want to make sure we're providing a lot of answers here and really good questions. And those questions are really informative to us, by the way. So, even the questions become a form of feedback for us. So I really appreciate everybody's engagement and the really strong questions and the clear, thought that's going behind these questions. I really appreciate that. But we are wanting to make sure that we bring some of that feedback full circle and make sure that you have information to help you make recommendations, along the lines of the second, third, or fourth option, and any thoughts about the prerequisite for stabilization. And we are expecting those comments back by January 24th. But again, we're going to continue to have open consultation and tribal consultation and urban confer around modernization. But helping us with those deadlines and we'll keep the project moving because you can obviously see that we'll have to render a decision about the approach. before we can do the meaningful work in the acquisition plan. We're doing as much of that in parallel as possible, as far as the preparatory work. But obviously we want to make sure that we've heard clearly from everyone before we make those decisions.
We do have a thank you for sharing this good information with us in the chat.
I appreciate that. We have a really committed team, and electronic health record is a personal passion for me, having worked in technology and operations and healthcare for over a decade. This is really a great opportunity for us to make sure the best technology is available to our patients, to our providers, to our care teams, to make sure that we have the tools we need to improve outcomes across the country. And again, as we're seeing with the pandemic, these digital tools are extremely critical with reporting, with public health, with care coordination. All those things are really coming to bear that are digital workflows and digital tools that we may not have traditionally put the priority on. And I think putting the priority on this at this time for IHS and our tribal communities is really critical, so that we put some infrastructure in place, that we raise the bar on the level of investment, and we make sure not only that we put a modernized infrastructure in place, but that we put the underlying structures in place to make sure that it's sustainable over the next decade or couple of generations. So really excited to have this opportunity, really excited to see the support from the communities. This is a really complex project that will likely involve tens of thousands of people and hundreds of thousands, if not millions of man hours into a structured project over the next 10 years. And so, it's not going to be easy, but I think this is very worthwhile work. And again, just reiterate that I appreciate the engagement and the thoughtful questions and comments that are being asked here.
Thank you. We have two more questions. Who is the best point of contact for the project?
So good question. So for the DTLL that went out, you can email myself or Mr. Randall Hughes as outlined in the Dear Tribal Leader letter with your comments. We are reinvigorating some of our methods that we used in the Modernization Research Project. So the listserv that everybody signed up for those updates, we're going to soon announce that we'll be leveraging that, so everybody doesn't have to re-sign up. We'll just build on that. But really the best point of contact right now is through the contact information on that Dear Tribal Leader letter, or you can reach out to me at Indian Health Service, and I think my contact information is on the slides.
Great. And then our other question is, for a tribe that wishes to purchase a COTS, will there be funding allocated to allow for this instead of adopting the new solution?
Yeah, great question. So when we have those conversations about 638 and supporting the full needs of the tribes across the country, what we're looking for is to establish, what does it take to support a modernized infrastructure? And our hope is that becomes a recurring amount, and then that would be available through the existing shares and methodologies that are already in place at each tribe, at each area, and at headquarters for the allocation of those shares. But we're not there yet. We don't have that reoccurring base to fund that yet. But that's definitely part of the discussion. I will say that, from a project standpoint, we have identified it as a potential scope risk. And what that means is under Public Law 93-638, tribes may have already compacted for their RPMS shares, or they may have left them and we're providing that support. And obviously, if we're providing that support, they've got to be on our list for our modernization effort. However, tribes that have exercised their 638 options or exercise some level of sovereignty have the ability to retrocede those shares, have the ability to come back to IHS and say, what does this package look like now? And we want to make sure that we again, are supporting a level of funding that makes this sustainable across the country and recognizes everyone's needs. So I hope that answers that question. Good question. Thank you.
We still have a few minutes remaining in the session. Just a reminder, you can put your questions into the chat, or you can unmute your line and ask the verbal questions. So we have one in here from Stuart. I echo the thanks for IHS doing this, Mr. Thornburgh's leadership. This is a huge effort, and I am so glad that IHS is moving forward with modernization and all that encompasses. It will improve patients, the services we provide, in our operational knowledge. He changed it to say patient care. And then it looks like another question is, how will the slides be available?
So I know that we intend to make the slides available, but does anybody have the details on how we'll share those?
So I know we're working to get the recordings live and available through the website, and we can also include the slides.
Yeah, thank you. Great question. We know that everyone needs these slides over the next few days as they provide responses, so we'll make sure to get that out quickly. And we'll get a PDF of the slides out pretty quickly. I thought we may have posted it already, but I don't have that reference.
Great. So it looks like that's pretty much the questions. We can do one last call for any questions in the comment box or chat box, or you can unmute.
Yeah, I did see a question about the website. So if you go to ihs.gov/HIT, that will get you to the front page with the background information and the project updates, as well as the ability to sign up for the listserv. The information is not out there yet, but it will show up there. Again, that's ihs.gov/HIT, and I'll see if I can put that in the chat.
Thank you for the link. If everyone can take a look at the chat, the link is now there for you to go to the website. So I don't see any other questions.
Now, I think we ended up with about 227 participants on the call. So just really want to thank everybody for their engagement. Again, I know how busy everyone is responding to COVID, and I hope that you and your families are staying safe and that your communities are recovering well. But any additional questions, or are we ready to close out?
Looks like we're ready to close up. There's no additional questions coming in.
All right. Well, I'd ask, I believe Ms. Sorrell will provide us with a closing prayer.
I want to thank everybody for joining us and for the wonderful information that was presented. I certainly want to end in a good way and being thankful and grateful for the work that is being done to really meet IHS's mission to provide quality health care to the people we're serving. I really also want to be very grateful and thankful for the work that they are doing to coordinate response and effort and vaccination for so many of us across Indian country as we continue to feel the effects of the COVID pandemic. So in a good way, with a good heart and a good spirit, I'm thankful for all that we do to serve our people and to make this a better place for our kids and the 7 generations to come.
Thank you so much. Have a great day, everyone.
Thank you, everyone. I think this concludes the call. Be safe.